I think, yeah, a lot of things have been already said. So I'm gonna do a bit of an overview of what I deal with. I mean, I like to, my talks generally, I kind of concentrate on patient presentations, and what I've done is a few videos in here. And I can also stop and ask, and let you ask questions in between if you wish. So if there's a burning question, it doesn't have to be burning, just raise your hands. Spine disorders in general, I mean, this is kind of a slide I have pretty much on all my talks. I put, this covers everything, as far as I know. It's going to be one of these 5 categories, all spine stuff that we deal with, or I deal with, or any of us deal with. The large majority is category 1, the wear and tear lot. And we've kind of mentioned some of that already. A scan find is inevitable, and there's then different things which are more likely surgical for me, and there's typical presentations within that, which I'll go through some of. And then we have the rest, which are written here, and I'll go through them one by one. I won't spend too much on this side here. So let's start off with the degenerative spine conditions. And this is probably a summary, and as we said, they're common. So herniation, stenosis, lumbar degenerative instability, degenerative low back pain. And I think we've already kind of, number one, spoken about a fair bit. This is another example of, so I guess similar to the scans that Tina was showing us. So you have a L4-5 disc here. So it is a sagittal MRI. Everybody can see that? Kind of no disagreement to the diagnosis? Yeah, okay, good. So this big thing here. The white here on the sagittal T2 is CSF, and the dark stuff here is the cord, end of the cord, and then the nerves here. This is kind of a normal axial scan, and I always show it to patients in clinic. They like seeing these things. I think like a visual kind of conceptualization. So these dots are the nerve roots, as most of us know here, surrounded by white fluid, and there's a white part here where it's this level. This chap was an acute presentation. But again, kind of tying in some of the talks from earlier, you'll start piecing together, okay, it's 4-5. If it was, what did we say? I'm allowed to say paramedian? Was paramedian okay? Something about like. But paramedian will take out the traversing nerve root at this level, which is the L5 nerve. If it's a lateral disc, I don't know if I've got pictures on here, but it'll be the exitor nerve root, which will be the L4 nerve root. So yeah, then I pieced that together with the presentation of the patient, the examination findings. This chap had a foot drop, which would be in keeping with this, and also some cord requiner symptoms. So he ended up having an emergency surgery. So cord requiner, as again mentioned, I'm not going to spend too much time on it, but it's a surgical emergency. We try to do things as quick as possible for them because recovery is more likely. And the significance of it is it's the same nerves that supply bladder and bowel. Obviously important for quality of life and important for people to maintain. And the evidence shows that an earlier decompression, you're more likely to reverse that to a degree, sometimes fully. So that's why we're trying to see them early. And then and a foot drop, a significant motor deficit. Again, try to do them early, maybe not in the middle of the night like a cord requiner, but within a day or two, especially if they're in acute presentation. Sometimes these patients come, nothing is black and white in medicine, although I try and make it black and white, nothing is. So, you know, sometimes you see like I saw in clinic, just didn't remember, I saw kind of a week ago somebody with a power 2 out of 3, but has been like that for 2 months. So I mean, obviously, as in, it doesn't make too much logic that all of a sudden that patient becomes an emergency within a day, because it's extremely unlikely that that's going to change their outcomes. And then, yeah, I put here the role. So, what do we do about it? I guess is the next question. We have somebody with a disc prolapse. If it's cord requiner, it's pretty much surgery because of to preserve function. Always, obviously, the patients have, you know, the pros and cons to weigh up, and cord requiner, they're stacked heavily towards surgery. But if it's not, and it's radicular leg pain, then there's a bit more choice, and I'll go through that in my second talk, I think. But just to touch on it a bit here is the role of a nerve root block, and I think it can be valuable because of patients like this, where you see a disc prolapse here, these scans. This patient came to me, presented late, where they had actually quite concerning symptoms, but for some reason or other fell through the net. And I scanned them late on, and you see the disc is pretty much gone. So you can have self-resolution of things, of disc prolapses, especially when, in my experience, when I call them soft discs. So if you look here, it's kind of on T2, it's a bit of a high signal, which means there's probably a bit of a fluid content to it, or it's a softer material. And they're ones which can improve by themselves, which is why a nerve root block or conservative management may help with these patients, because they're probably going to get better by themselves. Yeah. Any questions about disc prolapses, lumbar disc prolapses? Not really? I'll carry on. Okay. So we're still on degen stuff and lumbar canal stenosis. So yeah, various reasons to have a stenosed canal, but in this context of wear and tear, it's going to be facet hypertrophy, ligamentum hypertrophy, and this is the kind of typical presentation. Patients walk for a distance, they have pain, then they sit down, pain gets better, they walk again, same distance, have the pain again. It's quite typical, and for some, well, not unknown reason, they nearly all lean on shopping trolleys, except for the odd patient who tells me they don't shop anymore, they do online shopping, but apart from that, patients love it when you guess that they, have you been leaning on a trolley? How did you know? How did you know? But this is surprisingly consistent. So this is a typical presentation of lumbar canal stenosis. And again, in my experience, when it starts becoming symptomatic, it remains so. Things can wax and wane, but generally, once these things become symptomatic, they remain to do so. What's peculiar is that patient would have had that scan a few months earlier, but no symptoms. And I don't think we're ever going to get our head around exactly why the nerves decide to misfire at some point, not another. Nonetheless, when it is that presentation, then surgery is pretty kind of good for lumbar stenosis patients. My general kind of go-to chat to them is an 80% chance of improvement in leg pain, but in my heart of hearts, I believe that they will, especially when it's a typical presentation, as in it's extremely rare that I have somebody who doesn't. And we have an evolution of surgical techniques where initially there was the bigger incisions and a lumbar laminectomy where we're removing spinous processes and lamina, and more I've moved towards more minimally invasive, smaller incisions because of various things, including mobilizing them earlier, less pain, and patients love a smaller incision like this. I've got a video here because it'll give me a break a bit as well, so we don't need the noise on it. So this is an example of somebody with a disc prolapse, a bit of a disc protrusion, and a lumbar stenosis as well. Sometimes things happen in combo. So I'm going to say this patient probably presented with unilateral leg pain, but likely of neurogenic claudication nature, i.e. walking a distance and then pain was worse. So this is the kind of access device that I'll use for that. It's a tubular device, and incision is going to be something like 2 centimeters or so. And this is what I'm aiming to do. So it's to, well, that was quick, but the tubular device is basically docked onto the lamina. And well, here's the picture again. So it's docked onto the lamina, and the ligamentum flavum is underneath. After removing the lamina, you get onto ligamentum flavum. This is the elastic kind of tissue. And after the ligamentum flavum is removed, we start seeing theca. And in this case, I'm removing the disc. This is what a disc looks like, and retracting the nerves to the side, so I can get, so that'll be the traversing nerve root at that level, which is, I think, was it L5? I think if it was 4-5 level, it was L3, isn't it? And yeah, so I have to retract the nerve to get to the disc to relieve that compression. And even though it's a small incision, I can get to the other side and see the nerve on the other side. And this is kind of the view afterwards. This is just a dural sealant. 3 centimeters I liked a bit. Never trust a surgeon when they estimate size. Any questions about that? Lumbar stenosis, lumbar decompression, that kind of thing? Not really? Okay, well, we'll carry on. So back pain is an example. I'm just going to give case examples, so I'm not going to cover everything. This is an example of a patient who had a long history of low back pain. again, came to me after kind of exhausting conservative management, and I got them an MRI scan, and I mean, Tina might be unhappy with me, but obviously I sent for scans, a lot of scans, and I mean, look at this facet. I mean, it's just, you know, whilst again, degenerative findings, we've all repeatedly said can be incidental. It's hard to believe in the context of low back pain in this patient with really kind of obvious osteophyte on a facet that's not a pain generator here. This is kind of how it's looking. I mean, this is a kind of a more normal, on a sagittal view, a more normal relationship of a facet. Kind of look at it here. And then, you know, the books tell you, okay, facetogenic pain is more likely when you extend backwards. That's supposed to be more impingement of the facet. I don't personally see it like that. I'm a bit more pragmatic in how I manage patients. It's like, okay, we've seen this, here's your symptoms, here are your options, and they usually include carry on conservative management, and I'll again go through that in my other talk. And for somebody like this, I would go to a facet block, because for me it's almost a diagnosis as well. So I would block that facet, block the medial nerve, which supplies and I'll show you that in another slide, which supplies that facet, and see how they do. And this particular patient did quite well with that. I mean, it's a simple procedure, doing a facet block. And we're going to go through that in a bit in the other session as well by Marcus. I think we've gone through the demographics of low back pain, and went through some of that. But it's common and it's bad. This is the summary. And again, just on that topic of things that we can find which are not, we're not always taught these things. I mean, you get them with experience. So this is a patient who, again, kind of was having pain for many years, had an MRI, somewhere in tear changes. I think I usually, again, I follow these in a practical sense. Offered them facet block, didn't really help. Probably another type of injection I offered. I think probably I looked into the SI joints, didn't really help. Then got them something called a CT SPECT, which is basically a we give patients radio-labeled material, and then a gamma knife picks up areas of increased turnover, increased activity, and you can see kind of here is when you have a localized bright area, then that can correlate quite well with it being a pain generator. So this chap went on to have something called an ALIF, which is an anterior lumbar interbody fusion. And I mean, it's always hard because, you know, as all clinicians, they're different. You always kind of remember your good stories. It's always, you kind of block out the bad ones. But they generally do very well with this. But where we are taught that back pain, no kind of minimal options, and I'm certainly not saying this for everybody, but you do have the patient within these categories who benefits a lot, and sometimes it amazes me, either with a facet injection or something like this, where it's like, you know, you've turned my life around, etc., etc. As in, we can have amazing results, but for sure, not for every patient, and there has to be kind of quite strict selection criteria, at least for me. Any questions about that, degen stuff? We're all good. Traumatic spine, infectious spine conditions. I've had this slide on my talks for a long time, and this patient came to me in private clinic, and you know, elderly patient, quite bad back pain, and whenever an elderly patient comes in a wheelchair, you're like, okay, there's something significant here. Usually there is, as in they were walking and they can't anymore. Tendinous to percussion of the upper spine, and I don't know if you guys can see the problem that is here. And there's some fluid in the disc space here on the T2 scan, so you see the white here. And this is a discitis, and this is somebody who I ended up admitting, and they often need, well, they always need long-term antibiotics. There's an occasional role for surgery in the context of instability. Surprisingly, surgery, fixing them, when there's instability, makes the infection go a lot quicker. And the surprising part is we're putting in implants, but it's amazing their response sometimes. But nearly always they're managed with antibiotics. Tina showed us pictures as well of epidural abscesses, so kind of collections of pus around the nerves. In the presentation, we're going to be what the guys have mentioned, so cord dysfunction of where and relating to where that is. And again, you can get it in like all sorts of, again, this is somebody who saw me privately and came from London, found me on Google or something, and had a history of previous surgery overseas, and again wasn't out of his bed for months, and I think had been popping in and out of primary care, I'm going to say, and had a very bad discitis. This is a guy who I actually fixed, and I've not put his post-op images, but I did a pedicle screw fixation. I put a cage for that one 2-3 years back, I think, and this is the example of, I don't know if you have the time to read through that, you'll see kind of how it has changed him, because there's somebody from being bedbound for weeks, months, to all of a sudden kind of walking around and living his life normally again. So it can be very, very helpful for these kind of patients for instability pain. Instability pain can keep a patient in a bed unless it's sorted out, and you have to sort it out mechanically. There ain't no other way. And here's another example, again, somebody who was in our service in the NHS for a while, had I guess, I think I started off with one of my colleagues had a discectomy, and then another one, and then before you know it, had a discitis, and we didn't really know the bug, and then just carried on involving the levels, and this was a highly unusual situation. But again, in the end, they passed it on to me, and she had this, which is a big construct, but nonetheless, sometimes big operations are the right thing. She sent me one of her friends from the mum's school run, actually, so she must have been happy. This is her scan after. So yeah, there's a role for these big fixations in infection sometimes. Then we're on to, is there anything about infection? Any questions about infections?
I'm just wondering, with the infections, do you have to wait for the infection to clear before you operate, or
no.
do you just go in there? Yeah.
But it's not for everybody.
No.
But yeah, if there's actually, it allows the infection to be treated quicker. It's a still now, sometimes we have the debates amongst ourselves, my colleagues on call, and still there's kind of sometimes, can we or can we not, or an allied kind of, like anaesthesis, etc. They find it a peculiar concept. But it's not when, I think, and maybe Marcus will tell us in terms of orthopedics, because they've been immobilizing joints for infection for a while. I don't know exactly why. I'm sure somebody's kind of figured it out, or has the pathophysiology nailed a bit better, but it's definitely, when they have instability and movement, infection, number one, doesn't clear, and their pain is terrible. And the only way to get around that is fixing them. Okay, and then, we'll move on to traumatic spine conditions. And the one in the context of probably of this meeting mostly is going to be vertebral wedge fractures. And the common presentation for that is usually elderly, usually a woman, because of osteoporosis, obviously more common post-menopause, and very subtle trauma, or none. And then there's back pain, usually thoracic, worse on any impact type exercise, bumpy car journey, etc. And again, you can manage them conservatively, or you can offer them a kypho or vertebroplasty, and Pete will go through this later in one of the sessions, so I'm not going to spend too much time on it, but there's certain criteria in my head where I offer this, and it's acute onset, localized pain corresponding to, and this is where things get sometimes given a bad name. I remember a patient I saw where I think they had low back pain, but nonetheless a thoracic wedge fracture, and somebody had done a vertebroplasty. I mean, clearly that's not going to get better. And I don't think it gives a bad name for the procedure as well. So you always have to link it in, because all these findings can be painful, not painful. There may be indications to do something. There may be more slam dunks than this in terms of trauma. And I'll show you like this. So these are kind of more bad injuries, which we're not going to see in a clinic situation. It's probably a fall from a height. And you'll see there's a anaesthesis here, and facet fracture, I'm going to say. Let me go back. Yeah, so there's a perched facet, so the relationship with the facets are normal except for that area here. So on one side there's a perched or a dislocated facet on one side in the neck, fractures through the lamina. It's basically not a pretty scan, and a cord injury as a result. These are patients who need stabilization. Otherwise, and that's to prevent further secondary injury, because an unstable spine like that means that the cord edema ascends up with time, or they develop a kyphotic deformity here and develop something called a syrinx, which is because CSF runs around the cord but also runs in the middle of the cord through something called the central canal. When you block those dynamics, sometimes you get a syrinx. So that's why we operate on these. For this one, they had this and this, so an ACDF and a plate, and a lateral mass screw fixation I did as well for the patient. Also had this. I think this is the same patient, and I think anybody sitting there doesn't realise this is quite bad, which it was. So this is a complete transection of the cord, but again, we stabilize these not to recover. This would have been a power zero in the legs, though the cord will not be working anymore, but we stabilize them more for reduced ITU stay and management of pain and ease of nursing. So she had this for that area. And then I've highlighted two things here, because what I think, for me, I kind of like thinking about, and I do think it gets missed a lot, is kind of the combination of this with this. So having a degen problem causing something like a spondylolisthesis or a degen scoliosis. So wear and tear can cause excess movement, or it can be unequal, so you get more loss of height on one side, for example, causing the scoliosis. Yeah, and the particular thing that you'll hear me talking about a lot in these kind of talks is a degenerative instability, which means when they're standing, this is a definition that I don't know where I've taken it from, but for me, what I do is a stand-in X-ray and compare it to the lumbar MRI scan. And if there's an increase between the supine film and a stand-in film, then that means there's a listhesis. And it often is correlates well with pain. So if a patient has back pain, that usually means it's from this, if it's present on those images. So this is an example of that. I'll just show you the scan. So we have if you run kind of a line down here, this is forward compared to this. So there's an L5S1 listhesis. I'm going to say it's degenerative. I can't remember, but I think it's a degenerative listhesis. There's different types of listhesis. So you heard me mention earlier the athlete thing, and sometimes the listhesis can be not from wear and tear, but from a pars defect, which is a defect in the bone. I think I might have some pictures. This one is a degenerative one, and you can see again, going back to the anatomy talks, this is the exiting nerve at L4-5. So this is the L4 nerve surrounded by white fluid, nice and happy. This one's a bit squished here. So this is the exiting route here at L5S1 is the L5 nerve. So this patient had typical L5 pain, is going to be from this. So by, again, piecing everything together. And also she had instability, low back pain. And she ended up having this, which is a lumbar fusion, a PLIF fusion. And there's reasons why I do this. Basically, I'm trying to restore lumbar lordosis. We go back to the alignment talk for the anatomy side. And it's important because if you don't, then it's more stress on the joint above because they need to work harder. So you get an acceleration of wear and tear at the levels above if that isn't kind of restored to a good degree. And they do well. This one actually might be good for noise, so you can believe me as well, if it would.
Okay, hi, Marion. How are you?
Just need to turn out, I think.
So, Marion, we did L4-5 fusion for you for spondylolisthesis, for back pain and leg pain. Is that right? It's 2 weeks ago.
Absolutely.
Can I, and your how old's Marion?
75.
75. Can I ask you just to walk to the wall and back and just tell me how you're feeling there? Yeah, just walk to the wall and back. How's that feeling for you?
It's fine.
Yeah, just walk back. Your recovery was good?
Yes.
Yeah. Have a seat again. And no leg pain or back pain
No.
since? Okay, thank you.
Keith's asking close questions. This is another patient just to demonstrate the kind of the dynamic nature of this. So you look at this MRI, and you wouldn't say there's a listhesis here. And this took me a while to kind of think about this. But again, this is where I guess the history, etc., and a bit of index of suspicion is needed. But look at this X-ray. Look at the line MRI scan, and look at the listhesis on the X-ray. So it can be quite dramatic sometimes. And yeah, I did this for him. So again, a fusion, but with an XLIF, so a lateral interbody fusion. But I'll talk through some of the technical parts of that. This is another kind of image where I'll show her. This one is a part. This is actually a lady who kind of jumped out of a truck or something at some point in her life, and developed the pars defect. So you see it here on the side. I don't know if you saw me pointing to it. So this one does have a pars defect. So it's a traumatic pars defect. I'll just show that again, actually. So you'll see it there, that one there, that's a pars defect. And usually it's not clear trauma, but hers was, yeah, I jumped out of a truck when I was 18 or something, as you do. And then since then she's been having pain. And it got worse over time and became more symptomatic, and it's, again, a PLIF. And you see the restoration of the alignments that we get. And yeah, if you don't, if there's a theory, and again, this is the nuances of this. One of the theories is if you do a fusion, then you get acceleration of and some people kind of hold on to this, with whether it's surgeons or the public, because they hear about it. There may be more acceleration of wear and tear at the level above, because you've made it a hard landing, which is true to a degree. But if you look at this, it's kind of, there's no disc. It's going to be moving, and if it's moving, it's in a bad direction. So this is really functioning. So this is already overworking. It's how I think of it. So in my view, this level here in this particular patient is far better off after the fusion than it was before. Nonetheless, it's still a fusion, and it's not as if this level is like this one. So had she been like this and never jumped out of that truck, obviously she would have been better off. But that's where the nuances come into these. And again, another example, facet cyst and the recurrence Tina mentioned. So this is a facet cyst, a listhesis. Facet cysts for me are a sign of degenerative instability, nearly always. And the reason they come back is because surgeons decompress, don't fuse those patients. So for this one, I didn't even bother going and decompressing. I just fused them. It was a bit of an experiment, but it worked. So I just fused that segment, and this is before, this is after. It disappears because it's understanding the reason for things. It's more important sometimes from addressing the actual sequelae of it. So that's what this patient had, an XLIF. And these are the different types of fusions that some of them I've mentioned. Okay, well, let's talk a bit about the tumors in the spine. You can get them. They're often metastases. This one's a myeloma involving the vertebral body here at 2, 3, 4, 5, 6. I think it's C7 and T1. And yeah, she has a history of myeloma, so it's going to be from that. And this is the CT scan. You can see for your cells, there's like a huge gap here. Again, instability being the key word that I'm using today. This is unstable. It's not going to fall apart. It's strange how things remain when they develop over time, but the soft tissue seems to be enough to hold things together. However, it's a junctional area between cervical and thoracic. It's a lytic lesion. She has pain. These patients will do well with surgery and need it. There's different ways that I assess neuro-onc patients. So I'm looking at their neurology. I'm looking at what the tumor is, because myeloma, like this one, is actually sensitive. But I'm looking also at mechanical instability. This one is unstable. And then I'm looking at their overall morbidity. So there's an indication for surgery in this one, which is this corpectomy, for the reasons I just mentioned. And here's another example of a breast cancer metastases patient, again, lytic, and also they're not so radiosensitive, ended up having a corpectomy cage and then pedicle screws, did it in 2 stages. And then that's the main tumors in the spine are metastases, so coming from elsewhere. The spine is a common location for metastases, but we also have primary tumors, which are less common, and the primary tumors which are less common can occur within the dura or outside of the dura. So the main extradural one is a metastasis still, but it can be intradural extramedullary, like a meningioma or schwannoma, and it can be inside the medulla, inside the nerves, things like ependymomas. And the best thing to do is show a video. I think I have a video somewhere. This huge thing was a meningioma. Did this in lockdown with a lot of protective gear. How did he present? As you would expect, yeah, neurological problems, upper and lower limbs. So, yeah, there's typical appearance for meningiomas. They often kind of have a dual tail. I think this one may just about convince yourself. But it's not an unusual location for a meningioma. But yeah, I'll show a video instead. So this is an intradural extramedullary tumor.
Who presented with leg
L12.
weakness. Here we can see the
the patient, I think, presented with leg pain and weakness, this chap. So you can see it's taking up occupying most of the canal. Here's the nerve roots being squished to the side. And you can see here, look, you can tell it's a bit extramedullary because the nerves are all pushed, but it's within the dura. So there's typical appearances from them. I think people usually, well, I struggle often, but as in to know exactly whether it's extramedullary or intramedullary, but the imaging can help a lot. And again, the same kind of approach as the images before. So the spinal process is moved to the side. I get to the lamina here. And then I've removed, it seemingly, the lamina again. There's ligamentum flavum being removed, the ligament over the nerves. Here's the white shiny stuff is dura. And then I kind of want to keep it as dry as possible, so I packed it with something called flow seal. And then we open the dura, and CSF will come through. Underneath the dura, which, you know, the guys have mentioned some of this, there'll be the arachnoid layer, the spider's web kind of appearance, apparently. I hitch the dura back so I can kind of have a good look, and this is, you can already see it almost self-delivering in this case. And these things here are the nerve roots. So I'm kind of dissecting away at the attachments. And then also we'll be using Innomeds here for things like this, where we check, because often these tumors are often arising from a nerve root. So I'll be isolating one, directly stimulating it with the guys, making sure it's not supplying any major motor pin. And sometimes I've dissected, and actually they have, and I've dissected more, and it's like something stuck on it. So this, I check, there's nothing, then it means it's a redundant sensory type thing, which we then can coagulate and divide. So we use a lot of adjuncts in spine surgery. And it's progressed a lot over the past years, I would say. I mean, when I started out, we weren't using neurophysiology to the extent that we do now, for sure. It's a small thing, but it causes a lot of problems in the wrong area. And then we're inspecting the nerves underneath and close the dura. Yeah, probably. I've got a lot more slides, but I don't think there'll be too much time to do that.